Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The disclosures for guests on this podcast can be found in the show notes.
So I do have optimism that as we have more and more treatment options entering into the treatment landscape, we'll have fewer patients that are experiencing a refractory disease and potentially succumbing to the lymphoma.
Hello, my name is Loretta Nastoupil. I'm an associate professor and deputy chair of the Department of Lymphoma and Myeloma at the University of Texas MD Anderson Cancer Center. Welcome to this ASCO Education Podcast episode. It's my pleasure to welcome Dr. Chijioke Nze.
Hello, everyone. I'm Dr. Chijioke Nze, a hematology oncology fellow at MD Anderson. I'll be co-hosting this episode with Dr. Nastoupil.
We've seen notable advances in diffuse large B-cell lymphoma research lately, with novel treatments, including CAR T-cell therapy, offering the prospect of long-term remission for some patients. Yet, many patients are not even receiving second-line or later therapy, and even fewer are treated beyond the second line. How do you approach a patient with refractory diffuse large B-cell lymphoma? In today's episode, we'll explore strategies for management of refractory diffuse large B-cell lymphoma through two patient cases. So Dr. Nze, walk us through our first case.
Our first case is Frank. Frank is 60 years old and has no comorbidities. He presented with severe back pain in September 2021 and was evaluated locally. He had a CT scan that showed retroperitoneal mass, prompting further evaluation. He had a biopsy of the left retroperitoneal mass in November 2021, which was consistent with diffuse large B-cell, germinal center B-cell phenotype, Ki-67 of 90%. He had a subsequent PET CT scan which showed a large conglomerate and invasive left retroperitoneal hypermetabolic mass with satellite nodularity and contiguous bulky retroperitoneal adenopathy. It had bulky FEG-avid metastatic retrocrural and intrathoracic adenopathy as well. He was treated with R-CHOP for 6 cycles and at the end achieved complete remission. He had a PET CT a year later that showed new and worsening intensely FDG-avid abdominal adenopathy. This was new from a PET scan he'd had in January 2022 of the same year. He had a biopsy of this list of retroperitoneal adenopathy, which is consistent with relapsed diffuse large B-cell, germinal center B type, also Ki-67 of 90%. Locally, he was treated with ICE times 5 cycles and had a follow-up CT scan at the end, which showed persistent bulky nodal disease with periaortic regional nodes with Doval 5, consistent with persistent disease. He also was found to have new and more conspicuous nodes in other areas as well. He presented for his first visit at MD Anderson in September 2022. Dr. Nastoupil, when you see a patient like this coming into your clinic, what's your typical approach?
With diffuse large B-cell lymphoma, we are always hoping for cure with frontline rituximab containing anthracycline-based chemotherapy. And so it's always a gross disappointment when patients experience relapse. The timing of that relapse right now informs our current approach. And the reason I mention that is because there have been 3 large randomized studies conducted and reported out just in the last year demonstrating that CAR T-cell therapy is the preferred option for patients who experience either primary refractory disease or relapse within 12 months. And that is because they resulted in better outcomes than standard salvage-based chemotherapy and high-dose therapy auto-transplant in the setting of chemosensitive disease. Now, I have to acknowledge, of the 3 studies that were done, 2 were positive trials. So that's why currently we have Axi-cel, raxicaptogene silolysyl, or lisocabtagene mariclusal, and not Tisa-cel or tisagenlecleucel as CAR T-cell therapy options. And again, that's because 2 of the 3 studies were positive trials. Now, the challenge is, why would we have 2 positive studies and 1 negative trial? There are a lot of caveats to how those studies were conducted, but I think one of the biggest important lessons to be gained is that if you're going to consider CAR T for these high-risk patients, you want to do it as soon as possible. because that delay from identifying CAR T as a preferred option to actually infusing cells in a disease, in a case particularly like this, where patients may have bulky, aggressively behaving disease, that prolonged time may actually have an impact on outcomes.
Excellent. Thank you. So you've mentioned here early relapse. How would you define early relapse in this patient population?
Thinking back to how we've been approaching diffuse large B-cell lymphoma over the last 2 decades, the PARMA study, which was done prior to rituximab, suggested that for patients who had chemosensitive disease to a platinum-based salvage chemotherapy, which generally was at least a partial response on CT, if they went on to high-dose therapy autologous stem cell transplant, 50 to 60% of those patients could anticipate cure. Whereas for the folks who continued on salvage chemotherapy, 10 to 20% of those patients had favorable outcome. So we generally do try salvage-based chemotherapy, and for patients with chemosensitive disease, go on to high-dose therapy auto transplant. However, in the modern era where we've approached patients who've had rituximab as part of their frontline therapy, at least 2 studies, the Orchard study and the Coral study, suggested that only 20% of patients who relapse in the post-rituximab era, particularly within 12 months, were successfully salvaged with platinum-based chemotherapy and high-dose therapy autologous stem cell transplant. Now, fortunately, for patients who fail salvage, we have had CAR T-cell therapy as an option based off of 3 pivotal phase 2 studies demonstrating about 40% of patients could anticipate a cure with CAR T-cell therapy. So it only made sense to try and move that therapy up into second line, and the preferred population was those that had progressed within 12 months of frontline rituximab and anthracycline-based chemo. Now, to qualify for those studies, patients had to be considered fit for the control arm, which was salvage and auto transplant. Nonetheless, I do think for a patient like this, who's 60, without any other significant comorbidities, whose biggest challenge to longevity of life is his aggressive lymphoma, CAR T-cell therapy should be considered as soon as possible for this patient.
Is there still a role for high-dose therapy in autologous transplant in the new era, given the efficacy shown with CAR T-cell therapy?
I think there is. And the reason why I say that is the trials that were done really did focus on the highest risk patients, which were those with primary refractory disease or those who progressed within 12 months of frontline. Now, there are patients that will have later relapse. And so I do think for those patients, particularly those who are young and otherwise fit, should be approached first with a platinum-based salvage chemotherapy. And in the setting of chemosensitive disease, proceed on to high-dose therapy and autologous stem cell transplant. Now, what do we do for those patients who have a late relapse but are otherwise older or who have comorbidities that would make them suboptimal candidates for the high-dose therapy preceding stem cell transplant? We have a couple other options for those patients. So there was a trial done with liso-cel for patients who were otherwise older or not fit for intensive therapy. It's a single-arm phase 2 without a randomized comparison, but also demonstrated that liso-cel in second line later relapse patients who are not fit for intensive therapy resulted in comparable outcomes to what we would anticipate on that third line or later setting. We also have other non-CAR T-cell therapy options, such as tafasitamab, which is a naked CD19 antibody, which has been combined with lenalidomide in the L-MIND study, again, for patients without primary refractory disease and who would not be appropriate candidates for intensive therapy. So I do think we have alternative options. It's just when we look at the totality of the data right now, my conclusion is that CAR T-cell therapy, particularly for high-risk patients, is the most likely chance to result in cure.
Excellent. In a patient who we're considering CAR T-cell therapy, what are some of the short-term and long-term consequences or toxicities that we should worry about?
One of the challenges right now with CAR T and why it's still only available in specialized centers is the acute toxicity, which is really a derivative of its mechanism of action. We take patients' own T cells, we use a viral vector to introduce an extracellular receptor, but also a co-stimulatory molecule. So once these cells engage their antigen, sort of primed to react to that, and that can lead to pretty rapid T cell expansion, release of cytokines, recruitment of other inflammatory cells to that tumor bed. And as a result, a large portion of patients can anticipate to experience cytokine release syndrome, which again is the result of the activation of these T cells, the expansion and the recruitment of other inflammatory cells. Fortunately for most patients, this results in fever alone that can be managed with supportive measures. Occasionally, they'll have concomitant hypoxia or hypotension. And fortunately, few patients will have significant or severe toxicity. The other toxicity that's less easily manageable or less predictable is the neurotoxicity that can vary according to patient-specific characteristics, such as age, the amount of tumor burden, their performance status going into CAR, but even more importantly, the construct that's utilized with highest rates of neurotoxicity associated with axi-cel. Again, likely speaking to its construct and the CD28 costimulatory domain that is unique to axi-cel. As a result of these acute toxicities, patients are required to stay within 2 hours of their treating center for the first 4 weeks. And they're also discouraged from operating heavy machinery such as driving for the first 8 weeks following CAR T. So I do think this creates some barriers to access to this therapy for particularly the patients that are treated in community settings that may reside long distances from these certified CAR centers.
So you mentioned that obviously, given the specialized care needed for the CAR T therapy, that they're kind of localized to certain sites. What are some of these issues with access that you're noticing, both in the logistics of giving CAR T, but then also in patient access?
I'm hoping we're going to address one of those issues right now, which is education and awareness. Because we've had these 3 randomized studies and 2 being positive readout just in the last year, it's important to get the message out that CAR T-cell therapy for high-risk, early relapsed, refractory large cell lymphoma patients can result in a significant improvement in event-free survival and progression-free survival over the standard of care. And so being aware that this therapy can result in more favorable outcomes is step 1. Step 2 is we have to ensure that there are minimal barriers to getting those patients into these treating centers as quickly as possible. So recognizing who delivers the care, is it your traditional stem cell transplant physician? Is it a lymphoma doctor? What centers are certified? Some of these issues can be addressed with quick internet searches. So for instance, in our center, we have an 800 number for anyone who's interested in CAR T-cell therapy that connects them directly to a CAR T coordinator who can help them understand, do they meet the FDA-approved indication? Would they be interested in seeking consult? And we try and prioritize getting those patients in the door as soon as possible, since time likely does have an impact on outcomes. And then partnering with our community oncologists, who are going to be the primary oncologists for these patients leading up to CAR. And then after that 4-week window, when we're keeping the patients in close proximity to our centers, we often send them back. And so making sure that they're comfortable knowing what potential late toxicities to be on the lookout for, which include B-cell aplasia and risk for infection or prolonged cytopenias beyond just lymphopenia. And so again, there's a need for education and partnering with our community sites to make sure that there is successful handoff of these patients back after they've completed the monitoring for the acute toxicity. And then really trying to explore opportunities to utilize some of the better tolerated CAR T, such as liso-cel, in your non-traditional academic centers, those that are equipped to handle phase 1 studies or stem cell transplant, for instance, may not be affiliated with the university. So I think those are all types of strategies that could be employed to try and improve access for patients.
And then you mentioned the liso-cel, but are there any ways, and some of the toxicities, are there ways of predicting which patients will do better or worse? Are there ways to reduce toxicities? And is there any hope for things such as outpatient administration of CAR T?
So my answer today may improve over time as we get larger numbers and more experience. But what we currently understand is that the patient performance status, their degree of tumor, how quickly that tumor is increasing, LDH, and some inflammatory markers such as CRP or ferritin pretreatment can provide some insight into a higher risk of toxicity. And then obviously the construct that's utilized. Again, axi-cel has higher rates of neurotoxicity. All will have some form of cytokine release syndrome, generally speaking, but rates of grade 3 or higher are quite infrequent, particularly with liso-cel and tisa-cel. So it's multifactorial. That then raises the question, can we do anything to alter those modifiable risk factors? Can we reduce the disease burden? Can we improve the performance status? we do anything to reduce the inflammatory markers pre-treatment? And so those are strategies that are being discussed. And I think in general, as we get more effective therapies that enter into the treatment landscape, it's probably some of the best ways to try and reduce some of those risk factors.
Rounding that up, are there any exciting developments or things to look out for exciting therapies in the relapse setting?
A couple things beyond CAR T that I think we should all be aware of and anticipate to be in our toolkit relatively soon. Probably one of the most exciting is the development of the bispecific antibodies. So another challenge with CAR T is the requirement to collect these patients' own T cells and send them off to a central manufacturing site. And the turnaround time can be anywhere from 3 to 4 weeks. And again, in a situation where you have an aggressive disease, that can be a long time to wait. And so is there any treatments that are more readily available that, again, will be effective at reducing disease burden? And so bispecifics kind of fit those unmet needs to some extent. You have essentially two heads. One head's going to bind the endogenous T cells that eliminates the need to leukapheresis these patients and manufacture. And then the other head's going to generally engage CD20, which we know is an effective targeted antigen, particularly in B-cell lymphomas. And there are a number that are under development. We saw preliminary phase 2 data with glofitamab, paritamab, as well as combination strategies with mosunetuzumab. So I do have optimism that the bispecific antibodies will potentially enter into the treatment landscape. I anticipate they'll probably be used first post-CAR T, but will likely move their way into earlier lines of therapy. I've already mentioned tafasitamab in combination with lenalidomide, which is an effective non-chemotherapy option. We have antibody drug conjugates, such as loncastuximab, which is a CD19 antibody drug conjugate. It's essentially targeted delivery of chemotherapy, and it looks to have a pretty promising activity as a single agent in that third line or later space. And then polatuzumab, which is a CD79B antibody drug conjugate, in the relapse setting has been combined with bendamustine and rituximab, but also demonstrated significant improvement in the frontline setting in the Polaric study where vincristine was replaced with polatuzumab. So I do have optimism that as we have more and more treatment options entering into the treatment landscape, we'll have fewer patients that are experiencing a refractory disease and potentially succumbing to the lymphoma.
And then one additional question. How do you approach a patient who is not quite as fit in thinking about what their options are for later line therapies? You already mentioned some of these, but which of those would you prioritize in this setting?
Again, as we get more experience, we develop skills that help us sort of navigate all these different options. In my practice, if I'm even considering CAR T, I'm going to delay bendamustine until after I've collected those cells. I think that's one caveat that we do get nervous about the quality of those autologous CAR Ts if they're generated in someone who's had recent exposure to bendamustine. So that may help me sequence that later on. We have questions right now about what's the optimal sequencing of CD19-directed therapy because we have several options beyond just CAR T. As I mentioned, we have Lonca, and we've got tafasitamab and lenalidomide. Currently, we don't have prospective data that really informs that question. And there's a number of research studies underway to try and help us understand if there is a preferred sequence or even if it matters how we handle CD19 targeting. But for my older, frailer patients where I'm really worried they're not going to be able to tolerate something like Lysocell, or they're not going to be able to have that caregiver and they're uncomfortable relocating to an area where CAR T might be available, my general approach right now is to consider tafasitamab and lenalidomide first in that relapse setting, followed by either Lonca or Pola-BR. Selinexor is another option. It's an oral agent, though again, in my opinion, if we look at the totality of the data, maybe less effective than the other options. So I might reserve that as a last option for someone, again, with relapse refractory large cell.
Excellent. Thank you. This has been very helpful.
All right, so Dr. Nze, now I'm going to turn the table and ask you some questions. I'm going to change this up a little bit. This is now a 39-year-old female. She has significant comorbidities. She has HIV and, again, large cell lymphoma. So let me walk you through her case, and then we'll discuss some of the challenges, again, in a very different scenario, albeit a similar disease. So our female, as I mentioned, 39, pre-existing HIV. She's treated frontline with 6 cycles of R-CHOP and intrathecal methotrexate for CNS prophylaxis. Because of her comorbidities, again, not well controlled HIV. She also has a poor functional status at the time of relapse. This was a couple of years ago, and CAR T was not an option in second line, though she is someone who had a relapse that was beyond 12 months. So for her second line approach, because of her comorbidities, she actually receives rituximab in combination with high-dose cytarabine, dexamethasone, and oxaliplatin for 3 cycles, and actually achieves a chemosensitive disease and is referred to our stem cell transplant colleagues. Unfortunately, at that time, due to comorbidities, she was deemed not to be an appropriate candidate for high-dose therapy, and she's been monitored for signs of relapse. Despite being in the minority, she actually does not have a recurrence of her lymphoma, but has a number of other, again, challenges in regards to her comorbidity, including multiple infections resulting in recurrent hospitalizations. And so it's always been a challenge for me in being intimately involved in her case, deciding when she's presenting how alarmed to be about recurrent lymphoma versus infection, and how I might approach her in the setting of relapsed large cell lymphoma. So what role does prior type and responsive therapy play in treatment selection at your next line of treatment?
I think in this patient, it sounds like she got one adequate therapy and the initial presentation with R-CHOP, and then to get IT chemotherapy as well. She looked like she had a good response. I think the fact that she achieved a complete response and the duration of her response lets me know that she likely has chemosensitive disease. This in turn helps me to pick what to do next. As you mentioned previously, we know how efficacious the CAR T therapy is. But in someone like her who had a long duration, trying salvage therapy and proceeding to autologous transplant might make sense. I'd be interested in your thoughts.
Yeah, I agree. And I think part of the challenge, particularly when we're facing patients with HIV, they're often excluded from prospective studies. And so we're often in a scenario where we may not have the wealth of data to inform our treatment decision. But I do think in general, comorbidities play a major role when we're navigating treatment options. Because again, traditionally, we've used intensive chemotherapy as our mainstay of treatment. And there are clear criteria that patients generally should meet that help us predict how likely they are to have significant or severe toxicity from high-dose therapy. And this is a prime example of, even though she was young, her comorbidity made her a poor candidate for intensive therapy. I think the other sort of non-clinical factors that we sometimes take into consideration, because CAR T was approved off of single-arm phase 2 studies, again, none of which would have included someone like her, because of her HIV status, how do we extrapolate? For instance, if she had relapsed in that third line space and suggesting that she did not have significant infection or other significant comorbidities, do we have experience to proceed with an autologous CAR in that setting? So again, there have been a few cases where we have case reports where people have reported on their standard of care outcomes, particularly with CAR T and patients with active HIV disease. But one of the concerns I have in these scenarios is very selected. If you have active infection, that can make the acute toxicity with CAR significantly worse. And so again, we're trying to navigate a sort of limited data zone to try and help her and choose the right therapy. Again, you've met this patient with me. You helped care for her for some time, and you have a unique experience of also practicing in a county hospital where comorbidities, particularly like HIV, can be much more common. What is your perception regarding barriers to accessing CAR T as it pertains to social factors, clinical factors? And again, this is a case that highlights some of those issues.
You mentioned at first that she had uncontrolled HIV. So I think which one speaks to her treatment regimens of her non-malignancy related diseases, and trying to get that under control would be one of the first things I could think about. Thinking about how her care is managed and what kind of support she has are very important for us to think about as well. The other thing that's very important is a lot of patients who are seen in the community may not have access to such specialized centers such as MD Anderson, where patients do have access to clinical trials and CAR T therapy. And so patients who are unlike her, who might qualify, may not actually be able to get these therapies as well. Part of the reason it can be insurance status, which is what we see in a lot of our patients. So a barrier to get into the door. And then 2 barriers, lack of social support can be a big issue as well. And then there's also a big push in the community to improve the trust and awareness of these novel therapies, as you mentioned. So in a lot of community practice, some of the community practitioners may not be comfortable with these, and a lot of the patients may not have heard of these new technologies and also want to defer trying new therapies before considering having other people try the therapies before they consider them themselves. So I think all these things present specific significant barriers to patients in the community. One, their ability to adhere to care, two, their insurance and their ability to get care and the financial toxicities associated with that. And then three, really understanding the options that are available.
And again, just to try and illustrate a couple other points, we use a case here, which is a real case with significant comorbidities such as HIV, which again is something that is not frequently encountered and will have a large impact on treatment selection. What if I just told you this patient has comorbidities, but she has moderate type 2 diabetes, and as a result, she has mild renal insufficiency, ejection fraction is actually adequate? Would you have done anything different in this case?
No, I think in this particular case, I do think the fact that she did have a good response for a long duration of time and did seem to have chemosensitive disease, I would probably still have tried a salvage therapy and autologous transplant in this patient. In the event that she was refractory or had early relapse, then in that case, I would consider her to not be chemosensitive and would definitely have sought some more active therapies such as CAR T-cell therapy, digital available products.
And then one last question for you. So what if we just changed her age and we made her 79, but no other significant comorbidities? How would that have impacted your approach?
I'm going to turn that one over to you, Dr. Nastoupil, but I'm not exactly sure how I would treat an older patient with the same disease.
That's fair. So again, if you have an older patient who has a late relapse, but not necessarily someone you would consider appropriate for salvage chemotherapy and high-dose therapy, then I think tafasitamab and lenalidomide would be probably my first choice in that setting, just based off of the L9 study.
Thank you, Dr. Nastoupil, for a great discussion of the management of diffuse large B-cell lymphoma. And thank you to all our listeners. We appreciate you tuning into this episode of the ASCO Educational Podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.